Initial assessment. Introduction to the module. The initial examination is critical for determining the extent of the damage and determining the best treatment strategy. While the steps in an initial patient evaluation may appear to be independent and distinct tasks, it's important to remember that they can be completed almost simultaneously. To begin the initial patient assessment, there is no need to contact or touch the patient physically. You might start by doing a visual inspection and making some essential observations. You need to monitor a casualty's vital signs, level of reaction, respiration, and pulse while treating them. Learning objectives. At the end of this module, you will be able to determine when and how you should perform primary survey and secondary survey. Find out the assessment factors for an initial full-body examination. Monitor the vital signs of casualties. Primary survey. There are three main objectives of good quality initial assessment. Improving safety. Identifying acuity to ensure that the correct service treats the most time-critical patients within appropriate time frames and that appropriate prioritization occurs for the remainder. Improving efficiency in the system to ensure that patients do not wait unnecessarily for investigations or diagnostic decision-making. Practitioners need to obtain appropriate informed consent to ensure that practice remains professional and legal. ABCD protocol. Once consent has been obtained, clinicians should conduct a structured primary survey following the steps provided by the airway, breathing, circulation, disability, ABCD protocol. Try to determine whether the patient's airway is A. Open or patent, B. At risk of closing, or C. Not open when analyzing the patient's airway. In the paramedicine context, this distinction isn't often straightforward. For example, in the case of an allergic reaction, the patient's airway may appear to be open at first, only to obstruct due to swelling within seconds of the initial assessment. It should be mentioned that a patient with a closed or potentially closed airway requires immediate intervention. You can begin to analyze the patient's breathing while assessing and evaluating their airway, taking into account their attempt to breathe, such as the use of accessory muscles or grunting respirations, and noting the rate of breathing. Abnormal breathing patterns, such as agonal or Kussmaul respirations, fast, deep breaths that occur in response to metabolic acidosis, are possible red flags that indicate the patient is seriously ill. Check for a pulse and note its rate and characteristics as quickly as feasible to assess the patient's circulation. The carotid, brachial, and radial markers are all common pulse locations. The pulse rate may be slow, normal, or fast. The pulse could be weak, thready, normal, strong, or bounding, and the rhythm could be regular or irregular. Until proven otherwise, an irregular heart rate should be considered a possible red flag. Skin. You can get useful information from a hands-on examination as soon as your hand touches the patient. The patient's skin reveals essential information about his overall health, especially his circulation. Any signs other than warm, pink, and dry skin should be regarded as a potential red flag during the initial examination. Cool, cold, moist, clammy, hot, flushed, or mottled skin could suggest that the patient is ill. AVPU. During the initial assessment and visual inspection, the patient's neurological condition can also be determined. The neurological condition of an awake and cooperative patient differs from that of an unresponsive patient with snoring respirations. It is always necessary to perform a quick or short neurological exam on each patient. This can be accomplished using the AVPU system. A. Alert, can open their eyes and respond normally. V. Responds to verbal commands. P. Responds to a pressure or pain stimulus. U. Unresponsive to any stimulus. Equipment. Although cardiac and pulse oximetry monitors are not required for making an initial assessment, you must be able to determine whether a patient is unwell. An example is a paramedic recognizing a person in cardiac arrest and initiating basic life support until greater aid comes. Failure to recognize minor early assessment signs, such as respiratory arrest due to a drug overdose, might cause delays in providing necessary care. The ability to do swift and complete initial assessment, regardless of your level of experience, is critical to providing good patient treatment. If you have any equipment, you should use it to help your initial assessment of a patient. Primary survey conclusion. Following the primary survey, determine whether a patient is primary survey positive or primary survey negative. A primary survey negative patient is the more common finding, where the patient exhibits no significant threats to A, B, C, D, and therefore a more detailed clinical assessment can be conducted. A primary survey positive patient suggests that the practitioner has identified a significant abnormal finding, which requires further intervention, and often rapid transportation to an appropriate receiving faculty is indicated. Secondary survey. A secondary survey provides an opportunity to conduct a comprehensive physical examination. While the chief anatomical area for respiratory examination focuses around the chest, it is essential to consider other locations, such as hands, face and neck, as these may reveal additional findings specific to the respiratory system. Ensure consent for physical examination is still valid, given that your respiratory assessment involves exposure of the chest and peripheral examination of hands, face and neck. Full body examination. Hand assessment. The secondary survey should begin with the hands, providing useful information relating to respiratory and cardiovascular etiologies. Firstly, tactile reassurance from the practitioner can be helpful, in that any cardiovascular compromise can be assessed through the presence of pallor. Evaluate the temperature, clamminess of the patient's skin and capillary refill time. In addition, palpation of the radial pulse can offer further information regarding cardiovascular compromise where the pulse rate, character, rhythm, and pulse volume can be established. Capillary refill time, CRT, is defined as the time for a distal capillary bed to regain its color after applying pressure to cause blanching. Standard capillary refill time is usually 2 seconds or less. Other significant peripheral signs associated with respiratory disease are finger clubbing and nicotine staining. Finger clubbing, painless enlargement of connective tissue at the nail bed, can be associated with many respiratory diseases. The patient's fingers begin to develop a spoon-like appearance with the loss of nail bed angle. The cause of finger clubbing is unclear, but can be associated with lung abscess, pulmonary fibrosis, lung malignancy, asbestosis, and congenital heart defects. The best method of assessing finger clubbing is by looking across the nail bed and placing the fingers together to determine whether the space between the fingers is narrowed. Head and neck assessment. Begin by inspecting the eyes and checking the condition of the conjunctiva, which should have a pink and sticky appearance. In conditions such as anemia, the conjunctiva can present as pale, which may necessitate further investigation and hematological investigation. The practitioner can smell previous use of cigarettes on the patient's breath and consider hydration status through the moistness of the mucous membranes or condition of the patient's tongue. The presence or absence of pursed lips should be noted, as it can also indicate increased respiratory distress. Chest examination. A frequently used format for respiratory examination of the chest includes inspection, palpation, percussion, and auscultation, IPPA. Inspection. In normal breathing, it should also take twice as long to breathe out as in, demonstrating a ratio of 1:2 for inspiration and expiration. Signs of increased effort of breathing can often be displayed through the intercostal recession and the use of accessory muscles. Intercostal recession is a clinical sign of respiratory distress that occurs as a result of increasingly negative intrathoracic pressure causing recession or retraction of the chest. Palpation. Begin examination by light palpation across the thorax, which should not elicit any pain to the patient in normal circumstances. The chest cavity should feel warm and dry. The practitioner should lightly palpate over ribs for signs of tenderness or crepitus, especially following traumatic incidents such as falls or road traffic collisions. Healthy lungs should be stretchy and distensible. Lung compliance refers to the ease with which the lungs are stretched, as well as the equality and the depth, sometimes known as an excursion, of respiration. When compliance is low, more effort is needed to inflate the lungs. Percussion. Percussion of the thorax is a clinical skill that is both felt and heard as the practitioner attempts to determine the resonance or hollowness of the chest. Clinical examination findings from chest percussion in isolation have little clinical significance. These findings should be considered along with other information obtained during patient assessment. Auscultation. Auscultation by stethoscope is arguably the most important part of the respiratory assessment, as it evaluates the turbulent airflow through the respiratory tract during inspiration and expiration. The chief objective of pre-hospital auscultation is to identify differences in sounds produced from larger and smaller airways, and whether the air is passing through fluid-filled or narrowed airways, causing increased air turbulence. Monitoring vital signs. Vital signs provide information about the casualty. You can check for alertness, movement and eye contact. This can be a hands-off assessment. The information can help identify what to do next. Vital signs and values. Color, eyes and lips. Pink is normal. Blueness indicates low oxygen levels. Temperature. Feel exposed skin or under their collar. Cold skin may indicate hypothermia, dry skin, or shock, clammy skin. Hot skin may indicate heat stroke, dry skin, or fever or infection, wet skin. Breathing, quality and rate. Infants, 30 to 40 breaths per minute. Children less than 12 years, 20 to 30 breaths per minute. Children greater than 12 years, 15 to 20 breaths per minute. Adults, 12 to 18 breaths per minute. Level of consciousness, measured by AVPUA. Child or infant's emotional state will affect their vital signs greatly. It is important to both stay calm and reassure the child in order to assess them effectively. Monitoring should be repeated regularly, and recordings should be written down. Give this information to the doctors who are responsible at the hospital. Respiratory and renal regulation. You need to conduct a pH test. A rise in carbon dioxide concentration in the body varies the body's pH. Therefore, respiratory regulation works by eliminating carbon dioxide from the body. The body consumes more acid-producing food than base-producing, typically. Therefore, it must not only adjust pH, but also excrete H+. This task takes place in renal tubules, where hydrogen and ammonium ions are secreted into the urine. When H+ is excreted, sodium is exchanged. Assessment and monitoring. When prescribing to patients, it is critical to determine which patients need what based on a focused history, a guided clinical assessment noting the patient's observation. The paramedic's observation may include checking the fluid input and output, vitals, assumptions, interpreting blood findings, and, where applicable, paramedics given medications and assessment charts are essential knowledge for doctors before treating the patient. Highlights from the module. The primary survey should be a dynamic process where the assessment of A, B, C, D should be reassessed regularly. A secondary survey provides an opportunity to conduct a comprehensive physical examination. The presence or absence of pursed lips should be noted, as it can also be indicative of increased respiratory distress. A frequently used format for respiratory examination of the chest includes inspection, palpation, percussion, and auscultation, IPPA. Respiratory regulation works by eliminating carbon dioxide from the body. Congratulations! You've successfully completed the course. Thank you. Happy learning!